consenting process for a patient undergoing a CABG procedure. For example, this may be a question: a 40-year-old woman is admitted for coronary artery bypass surgery. How would you explain the surgery to her? So firstly, I think about the patient environment, then I do a history and examination of the patient, undergo the indications for the procedure, explain how the procedure is done, explain the risks and benefits of the procedure, any alternatives, and address any patient concerns. So in terms of patient environment, I'd want a quiet space for consultation with family members if they would like. I would want to check for command of English, and if it's inadequate, provide interpreter services if necessary. Assess the cognitive ability of the patient. This is vital for informed consent. And when consenting, use lay language and visual aids as required for clarity. In terms of history, I will focus on symptoms of ischemic heart disease, risk factors, current medications, and any allergies to gain an appreciation of the disease severity. I would also ask about factors that may predispose the patient to developing complications following surgery as per the Euroscore risk prediction algorithm for predicting cardiac surgical mortality, which takes into account age and sex, cardio-cerebrovascular risks such as acute coronary syndrome within the last 3 months, or cerebrovascular accident, cardiac surgery, and carotid bruits, respiratory assess for COPD or infection, renal check for acute kidney injury, chronic kidney disease, electrolyte disturbances that predispose patients to arrhythmia, hematological, anticoagulation, bleeding, diatheses. And low risk are those who have 0 to 2 points and they have a mortality rate of 1.3% with a CABG. Medium risk are those with 3 to 5, which is 3%, and high risk is 6 or more points and they have a 10 to 12 risk of cardiac surgical mortality according to the Euroscore. I'd also, on examination, do vital signs, take the blood pressure, heart rate, and rhythm in particular, as well as do a full cardiorespiratory examination to look at features of heart failure, for example, an elevated JVP, peripheral edema, a third heart sound, a displaced apex beat, and murmurs such as aortic stenosis or mitral regurgitation. Then I would go through the indications and contraindications for CABG. The aim of CABG is to revascularize the myocardium that is currently perfused by coronary arteries with greater than 50% stenosis. The indications, according to the American College of Cardiology and American Heart Society Association, says that CABG would benefit those patients who have left coronary artery stenosis greater than 50%, 3 vessel disease with proximal LAD stenosis and poor LV function, 3 vessel disease in asymptomatic patients with mild or stable angina, disabling angina, stenosis of proximal LAD and proximal circumflex, more than 70%, 1 or 2 vessel disease in a large area of viable myocardium in stable angina, ongoing ischemia in non-STEMI unresponsive to medical therapy, greater than 70% proximal LAD stenosis and an ejection fraction less than 50%, or demonstrable ischemia on non-invasive testing, poor LV function with viable non-functioning myocardium above the anatomical defect that can be vascularized, STEMI and failed PCI, persisting pain. Contraindications for CABG include those who are asymptomatic and at low risk of myocardial infarct, have numerous comorbidities which would place them at a high risk of death following CABG, and also age is a relative contraindication because the older they are, the more likely they're going to have perioperative complications. So important to balance the risk and benefits of this procedure. I then talk about the peri procedure, so that includes preoperative, operative, and post-operative. So preoperative, I would tell them that they need to stop smoking more than 2 months before the operation, do routine pre-op blood investigations, and pre-medication in order to reduce myocardial oxygen demand by decreasing heart rate, systolic blood pressure, and improve myocardial flow with vasodilators by putting them on a combination of beta blockers, calcium channel blockers, nitrates, aspirin, but withhold thiopyridine more than 5 days prior, and benzodiazepines given before surgery to prevent tachycardia and hypertension from anxiety. In terms of preoperative investigations, bedsides, I would do an ECG, bloods, grip and hold, full blood count, make sure that they don't have a surgery, they don't have infection, by the elevated white blood cell count, EUCs, LFTs, coagulations, screen for MRSA and VRE, and in terms of imaging, chest X-ray, echo, carotid, Doppler, and coronary angiogram. The procedure itself can be divided into anesthesia, harvesting the conduit for the cabbage, the incision, the cardiopulmonary bypass, and the graft insertion. So anesthesia is general anesthesia. They'll be intubated and an indwelling catheter will be inserted. Then they're going to harvest the conduit, so the vessel, to bridge the blocked artery by either using the saphenous vein from the leg, the radial artery from the arm, the internal thoracic artery, the splenic artery, or the gastroepiploic artery, which is less common. The incision will be made as a midline sternotomy, and then they'll be put on the cardiopulmonary bypass machine, which will basically function as the heart itself. So the aorta and the right atrium would be cannulated, and cardioplegia, which is a cold fluid, will be administered into the heart to cause asystole of the heart. The venous blood from the right atrium is filtered through the cardiopulmonary bypass, oxygenated, and then returned via the aorta. Then the graft, the distal coronary artery bypass targets are easily identified, and the conduit is sutured to it accordingly, restoring blood flow to the distal segment of the myocardium. In terms of post-procedure, the patient will have antibiotics post-op, antiplatelet therapy such as aspirin and or clopidogrel, beta blockers, ACE inhibitors, statins, glycemic control, removal of the indwelling catheter, and removing of the temporary heart pacing wires. In terms of the risk and benefits, the benefits include relief of symptoms and reduction of the risk of future acute coronary syndromes. The risks include a risk of death, which is less than 1% in major cardiothoracic centers. There's anesthetic risks such as anaphylaxis, cardiac and non-cardiac complications. Cardiac complications include acute myocardial infarct, early graft inclusion, which can be 5 to 10% with saphenous vein grafts, low cardiac output by ventricular dysfunction, life-threatening arrhythmias, pacing wires are needed, cardiac tamponade, and pericarditis. Non-cardiac complications include infection of the sternal or leg and arm wounds, neurological such as stroke or peripheral neuropathy, pulmonary such as pulmonary embolism or pneumonia, and kidney, acute kidney injury from intraoperative hypotension, post-operative cardiac complications that impairs perfusion to the kidneys. Post-cabbage, many patients feel weak and need up to 6 months to return to normal function. They're not allowed to drive and they need extensive cardiac rehabilitation with physiotherapy. In the terms of alternatives to cabbage, 1, you can do nothing and just give them medical therapy, or 2, you can do percutaneous coronary intervention where they put a stent into the coronary vessels. This is shorter, there's less pain, and there's a tiny scar. However, cabbage is still recommended for those most likely to do well, such as those with 2 to 3 vessel disease and high-risk scores. And the Syntax study is a randomized controlled trial that compared cabbage and PCI, which demonstrated that high-scoring patients, i.e. 3 vessel disease or left main coronary disease, cabbage offers a superior survival advantage, reduced repeat interventions, and reduced overall adverse cardiovascular events up to 4 years after revascularization. And finally, you want to address any concerns raised by the patient and family. Thank you very much for listening to this presentation.